Now, on this ECG, take a look at this. Twist, 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 narrow point. Twist, 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 narrow point. What's another name for this? It's called polymorphic ventricular tachycardia. Okay? Polymorphic ventricular tachycardia. Allow the name to speak to you. Polymorphic, various changes in shape. Of whom? The ventricular representation of your ECG is your QRS complex. Okay? The most common type of polymorphic ventricular tachycardia that you will be responsible for is this one. It's called Torsade De Pointes. Okay. Now, with Torsade De Pointes, what preceded this? Wasn't a predisposing factor. Well, the QT, which is all ventricular activity. All. Let me give you some important points. Pay attention. Pay attention. QT. All ventricular activity. Let's do QRS complex first. What does that mean to you? Ventricular depolarization. What does that mean to you? The ventricles are going to whoop, contract, whoop, contract. Which axial potential are you bringing into play here? 0, 1, 2, 3, 4 or 4, 0, 3? Which one, please? 0, 1, 2, 3, 4. Do that for me. It'll make your life a heck of a lot easier clinically. Please do that for me. Okay. So, with that QRS complex, and let's say that you want to block it for whatever reason, You want to block it. What kind of drug might you be thinking? I want you to block that depolarization. A phase 0 blocker. What is that phase 0 in 0, 1, 2, 3, 4 with mechanical type action potential? Good. It's a voltage gated sodium channel. Okay. What if you gave too much of that voltage gated sodium channel class 1 type of antiarrhythmic? If you gave too much, then what may then happen? Prolong the QT. Let me give you another one. Tell me about that T wave. I told you QT is what you're paying attention to. Tell me what T wave represents. Ventricular repolarization. Let's talk about that action potential again. 0, 1, 2, 3, 4. Which phase of action potential, 0, 1, 2, 3, 4, represents the T wave and ventricular repolarization? It's phase 3, isn't it? Think about that. Of course it is. Repolarization, potassium efflux. I want you to block the potassium channel. A class 3 drug, drugs such as amiodarone. What may then happen? You prolong the T. Prolong the T means you prolong the QT. What do you know about 1 and 3? What do you know about class 1 and class 3 antiarrhythmics? Are you seeing as to how beautifully we're able to walk through the physio, the disease, and the management? Adverse effects. Class 1 and 3 may then cause long QT syndrome. That you already know. Now you're putting it together, and you're predisposed to this sucker, which is your Torsade De Pointes. Or you're born with this genetically. And one that you definitely want to know is Romano Ward. Why did I say Romano like that? It's because I need you to know that Romano has no deafness. Okay? Romano Ward is congenital long QT syndrome. Couldn't help it. Born with it. But there's no deafness. Where you have another one where Lang-Nielsen is involved. That's also congenital long QT syndrome, and that is involved with deafness. Can't miss this, but there's a lot more going on here than meets the eye, and you know that. You can't just look at this and be like, oh, it must be Torsade De Pointes. That was such a simple question. No such thing. There's history behind this, and we walk through some important ones. Let's continue. So, with Torsade De Pointes, associations. Now, be careful here. I want you to do something with me for magnesium. Who's this patient? 3rd trimester, female, pregnant. She goes to the bathroom, and she's urinating quite a bit. Her weight gain is not in proportion to her gestational age, which actually means she has accelerated weight gain here. Her blood pressure is 160/90. Whew. She has hemolytic anemia. How do you know? Well, maybe she seems a little jaundiced. There's going to be increase in liver function tests, your transaminases. And the platelet count, 50,000. Put all this together. Tell me what's going on. And what are you worried about? And why am I bringing this up here? Because I'm referring to preeclampsia. Preeclampsia, what happened? A pregnant lady, 3rd trimester, okay? And she was urinating. When she urinates, quite a bit, okay? So because there's protein loss. In addition, because of protein loss, I told you there was weight gain. Accelerated. Greater than what was expected for gestational age. Because of edema. Edema. I said there was blood pressure 160 over 90. What's the definition of hypertension? 140 over 90. And I told you there was hemolytic anemia, elevated liver transaminases, and there was low platelet. HELP syndrome. That's worst case preeclampsia, is it not? Yes, it is. So, tell me, next step in management, magnesium. Why? Because if you don't give magnesium, there's every possibility that preeclampsia may go on to eclampsia. So what was in this patient, or what is being introduced to the patient that goes into eclampsia? Seizures, right? Seizures. So my point is this. Magnesium, if you're deficient of it, may result in seizures. Hypomagnesemia, you're rendered, predisposed to Torsade De Pointes. So I need you to think, if you want, in layman terms, seizures of the heart and seizures of the brain. Okay? And point is, you give magnesium, or you're looking for a patient, perhaps, that has hypomagnesemia. Aren't you worried about seizures in such patients? Are you worried about Torsade De Pointes in such patients? Of course you are. Put things together. Do not memorize things one at a time. Try to parallel your organ systems. And if you can't do it effectively, that's why I'm here. Use me. Bradycardia. What's that mean? You're slowing down your heart rate. The more that you slow down your heart rate, you're predisposed to what? Twisting. Also, what about that QT? We already talked about drugs. Let's take a look at a few of them. We have antidepressants, phenothiazines, quinidine, a sodium channel blocker, procanamide, sodium channel blocker, diazepyramide, sodium channel blocker. Well, why am I bringing these up? Because I just told you, class 1, by blocking that sodium channel, you might be doing what? At creating a long QT scenario. Fluoroquinolones, antibiotics, and antifungals. Here's some ABCs. Antibiotics, antifungal, antipsychotics, antidepressants. At least know some of those. And antiarrhythmics. You actually have A, B, C, D. Obviously, I don't know my alphabet, but you do the alphabet and you walk through anti. A, arrhythmia. B, biotics. C, you might want to pronounce it being psychotics, if that helps. D is going to be depressants. Now, anyhow, work with the C there a little bit, okay? Can you do that for me? Thank you. Appreciate it greatly. Let's move on. All right, ventricular tachy, we have Torsade De Pointes. What happens? Worst case scenario? Look at this. Decreased cardiac output, syncope. That's scary. The ventricle is not working properly. May lead into VFib. You don't want this at all. All right, this is no joke. You try to control this ASAP. Worried about cardiac arrest and death. Next, corrected with electrolyte imbalance. Which one? Which electrolyte are you focusing upon most importantly again? Magnesium. Good. Okay. So if you're hypomagnesemic, think of seizures. Next, setting up hemodynamic instability. What's your next step of management? Good. Electrical cardioversion. Electrical. What's hemodynamic instability mean to you? Distress, dizziness, syncope, low blood pressure. Okay. Good. Isoproterenol or dobutamine. What about these? Well, this could be used to maintain a tachy utilized. So maybe, just maybe. So just keep that in mind. A non-selective beta agonist, isoproterenol, dobutamine, a selective beta-1 agonist. Now we get into worst case scenario. Tried everything you could. Maybe it wasn't effective enough and your patient still goes into VFib. Very, very obscure type of Curious complexes. This is not ventricular tachycardia. Your patient is very much at risk for standstill. Torsade De Pointes, patient unconscious, result in sudden cardiac death. So this is no joke.